Thank you, everybody, for joining again. I will remind you that this is our third meeting of the Healthy California for All Commission. I'm grateful to all of the commissioners for joining again, and for our consultant team for doing an amazing amount of work between our last meeting last month and this one today. And I just want to say a deep appreciation as the participant count keeps climbing for all of those who are joining the Zoom to listen in and at the end give us your feedback and comments on all things that the Commission is consumed with. Before I get into further opening remarks, I wanted to turn it over to Karen to remind us of the protocols of our meeting.
Thank you, Dr. Galley. And I just want to say on behalf of the consultant team, and I think most, if not all of us here, we really appreciate you and Dr. Chen being here amidst this national and state crisis and moving this forward amidst all of that. So thank you so much. So just quickly, in terms of the virtual meeting protocols, just a reminder that this meeting is being recorded. Commissioners, you have the ability to mute and unmute and the option to be on video. And of course, it looks like most of you have opted for that, and we're so pleased. Please do mute yourselves when you're not speaking so that there isn't feedback or background noise. In this meeting today, we're going to ask you to use a certain symbol to indicate that you'd like to speak. It's different than last time. It's the yes feature with a green checkbox, and you still access it by hovering over the bottom of your Zoom screen and looking for the participants icon. For some, I suppose it's possible that participants might be at the top of your screen, but you're looking for the participants icon. You're clicking on that icon, and then over in the participants panel, you'll see everyone's names. And at the bottom left corner, there should be a yes with a green check mark circle. We invite you to practice now just clicking that. That will be your indication when we're in the main session that you would like to speak. And so when we indicate it's time for discussion and feedback, we will be first looking to that panel. If you are really struggling to be able to do that, you can always unmute yourself and let us know, but we'll turn to that first. And then you will need to click on that yes check mark to remove it from your name when you have been offered the opportunity to speak. Okay, and so then in terms of members of the public, yes, thank you so much for being here. We see many individuals have joined us to listen in. You can listen to and view the meeting. For written public comment at this meeting, we're asking members of the public to use the chat feature. That is the one Zoom feature available on this platform today to provide written comment here in the Zoom setting. So if you would like to use that written public comment feature, you can look at the bottom of your Zoom screen and see the chat icon. Click on that, and then you will see the pop-up box where you can provide written input into the text box there. Commissioners, you're welcome to use the chat feature as well, but this is for everyone today. And so the chat box will move very quickly, and it would be easy to lose sight if you're trying to get our attention. Another way to provide written public comment is through the email address, healthyca4all@chhs.ca.gov. We will also be taking verbal public comment today at both agenda items during the meeting. And so we will provide specific direction on how to provide that verbal comment at that time. All of the public comment that is provided today, both in written form and verbally, will be captured as part of the public record. All right, with that, again, I'd ask everyone to mute if you're not speaking right now. And I will turn it back to both Dr. Chen for roll call and then to Dr. Galley for some more remarks.
Great. Thank you so much, Karen. So I'll take us through roll call. Commissioners, as I read your name, if you can just say hello to indicate that you're here. And Karen, did Jenny and Senator Pan join us yet?
Let me check with our team. Have we seen Chenny Jen Hansen or Dr. Pan? Not at this time, Dr. Chen.
No worries. All right, so I'll just start with Secretary Galley, who's here, and we're muting, so I can just say hello for him. Carmen Comsty.
I'm here.
Dr. Hernandez, Sandra Hernandez.
Good afternoon, I'm here.
Bill Shao.
Hello, everyone.
Hello. Can folks mute if you're not speaking, please? Dr. Rupa Myra.
Maria.
Maria.
Hey.
Dr. Bob Ross.
Hi, Alice, I'm here. I'm here, can you hear me?
Yes, I can hear it. Dr. Chen, you got muted. I apologize. There you
Excellent.
go.
Hi, thank you. Richard Scheffler.
Yeah.
Hi, Richard. Andy Schneider.
I'm here.
Sarah Phlox.
Good afternoon, present.
Excellent. Janice Rocco.
Here.
Antonia Hernandez.
Here.
Excellent. Anthony Wright.
Good afternoon.
Peter Lee.
Hello.
Don Moltz. Don, I think you're excellent.
Yeah, I'm unmuted now.
Assemblymember Wood.
Here.
Excellent. And then Will Lightbourne.
Here. Good afternoon.
Excellent. So we're all here except for Jenny Chin Hansen and Senator Pan at this point. So at this point, I'll turn it back over to Secretary Galley for introductory remarks.
Thank you, Dr. Chen. Hold on. Okay. So I just want to take a moment and welcome Will Lightbourne to the commission. He is newly appointed as our Department of Healthcare Services Director. We are grateful for Will's return to service after a brief retirement, whereas I understand it, close family members said, get out of the house and go back to work. We are the beneficiaries of that, and he's helping us guide what is a key and important department, but today, importantly, joining our effort to look at sort of building on the commission's work. I want to go to the next slide, if that's okay. Just an update quickly on the environmental report. Since our last meeting, the team has taken the written comments from the many commissioners and have compiled that feedback into the comprehensive report that is going to go back out to all of you with a period of additional time for input before we link that and get the public input to that document so that it can be posted soon. I know Dr. Beinman and team may have some additional comments there, but I just want to tell many of you who I know were eager and interested and reached out to us to make sure that feedback was incorporated, that we heard you and built that in, and look forward to getting that work product out, especially now given the overlay of the COVID issues that I know are going to make it into that report. Can we please go to the next slide? Want to talk a little bit about our commission work plan. Since the last meeting, where we heard a lot of great feedback and even in some comments that we've received by email or in single one-on-one discussions, really focused on moving the commission to more frequent meetings. So instead of our quarterly meetings, we are going to have monthly meetings, as you see at the second bullet point. Today's the first one of those, and then we will continue with one on those dates. And although they'll be shorter, we hope that it allows us to have additional touches, keep the momentum going on discussions. We also heard the feedback to focus on major change rather than incremental steps. And I think for some of us who are diehard incrementalists, we'll see how that works, but certainly the major change is what many of us hope to string along the incremental steps to achieve anyhow. And then we also heard the input to gather broad input across Californians. So not just those people who are both on the commission or who have joined this meeting as part of the public, but really to reach into the communities that we know have the most at stake based on how we get healthcare to everybody across the state. And the experience with COVID, as we talked about in our last meeting, was very much around those populations that we continue to try to support during COVID, but also that we understand and know that primary care and good and convenient access to healthcare services makes a difference overall. We will be using each of our meetings to do a deep dive into major design features of unified financing, and this will include what we will preview and try today for the first time, these breakout conversations with our commission. And then I just want to mention that we heard about the community engagement process and the interest, reaffirming what I think our leadership team and our consultant team has felt all along, that building and getting our tentacles deep into community is important. I know that we are working to create the forum for that broad community engagement. I just want to acknowledge that some of you have reached out with your thoughts and ideas on that, and we will incorporate that. Dr. Maria, I just want to acknowledge your comments also on the importance of having transparency in this process and really building it from the ground up in a way that I think all of the commission can be proud of as a top-notch engagement approach. Can we go to the next slide? So I'm gonna just stop there. I wanna see, before I introduce our first sort of substantive issue on the agenda, and I know Dr. Beinman, I don't know if there's anything that you or Dr. Chen wanna add that is important. If not, I'll just move on. Can see thumbs up or not. If you wanna add, please do.
I think you did a terrific job, Dr. Galley. Thanks very much. And we are, as you said, working hard on revising the report, and very much appreciate the input of the commissioners and the public in terms of their comments. And I think this will result in a much improved report. So we look forward to sharing that back with you soon.
Thank you, Dr. Ryman. I will just say, before I introduce Dr. Angel and have the privilege of introducing her to the commission, just want to acknowledge that compared to the last time we were together for this commission meeting, and what has changed is really a true increase in our caseloads of COVID-19 across the state. And what we are beginning to see more and more is the disproportionate impact on certain populations. And we've always clearly known about older Californians and the disproportionate impact on communities of color and the essential workforce, as we have begun to call that sector of our community. But very much today, we see thousands more cases on a daily basis, hospitals filling up at a rate that we aren't accustomed to. And as I like to say, the first couple of months was really a surge in planning, not so much a surge in patients. But now we are really seeing a surge in patients. And it's appropriate to sort of talk about that moment, not just because that is really squarely on the mind of so many healthcare leaders, both at the state and across the private sector and in our counties, and so many of you thinking about what COVID means. But it's also, I think, apropos of what Dr. Angel's going to talk to us about, which has this broader look at health equity and healthcare financing and what we know and what we don't. But really at the COVID lens, what we end up seeing, and many of you raised this at our last meeting, is that access matters, chronic disease care matters, and when we don't have a solid system to support all Californians, regardless of income, regardless of race or ethnicity, we end up seeing a worldwide pandemic do what is sort of predictable and almost expected. And if we're going to make a difference, even in this pandemic and future health challenges, not quite at this scale, hopefully, but other ones that will be part of our story in the years and decades to come, this is an issue that has to become squarely married with the financing schemes that all of us think through and build upon. And as we look at the differential ability of different nations and different communities in our own nation to handle the stress and impact of COVID, I think a lot of the difference in our reaction and our ability to respond has to do with how our underlying health systems are built. So with that sort of opener, I want to take a moment and introduce somebody that I was proud to recruit to California, Dr. Sonia Angel, who is our Director of and State Public Health Officer for the California Department of Public Health. One of the reasons why I was so interested in recruiting Sonia back to California, where she went to medical school at UCSF and then went east to do residency and work in New York and at the CDC and a number of other amazing experiences that really create her into one of, in my view, both a contemporary leader on health equity issues and thinking about how equity translates into issues of policy and real program and rubber meets the road sort of activities, and the leading work she did in New York around things that really matter very much at the community level. So I appreciate all of that as coming together to really support a visionary leader for California who can, I think, guide our way in many, many ways. We've all been challenged by COVID, and her laser focus on equity issues has not been wasted on anyone in California, and we're grateful to have her leadership. So with that, I'll turn it over to her to run through our slides, and then we'll have a little time for conversation. Dr. Angel, take it away.
Thank you. It's a pleasure to be here. Just want to make sure you can hear me.
We can.
Fabulous. All right. So I am really honored to join you all today and reviewed the report also that was presented at the last meeting to understand a little bit more about the direction and understanding that there is of healthcare and unified financing here in California, and this opportunity now to talk with you a little bit about health equity and what we're seeing through the eyes of COVID now. Dr. Galley often says that COVID is the great unmasker of inequities and the accelerator of inequities, and that is remains true, and we will continue to beat that drum and have that discussion, because that is really the only way we're going to create the change that we all believe in and need to see. So next slide, please. So I'm just going to, I have about 10 minutes to talk with you, 15 minutes with the questions. So I'm going to move through this relatively quickly, but in a very focused manner. I'm going to talk about first kind of where we are now with respect to COVID, talk about some of the emerging COVID-19 inequities that we're seeing. And because of the limited time, I'm going to talk about those that we're seeing with respect to race, ethnicity. But let me first acknowledge, most importantly, that this is not the only form of inequities that COVID-19 is unmasking as we speak, and that requires our attention. And then finally, I'm going to talk a little bit about some considerations and opportunities as you consider your work around unified financing and inequities. So next slide, please. So this slide shows California's COVID-19 milestones over time. You all may recall back in January 25th, we had our first cases in California. And as we marched forward to our first deaths, our emergency declaration, our first community acquired death that was not in a traveler, and started to experience community spread, followed by the WHO declaring it a global pandemic. And then in California, our stay-at-home order on March 19th. By April 8th, we had reached a total of 17,000 cases. Now that pales in comparison to our 289,000 cases, which we are reporting today. But I bring up the April 8th date because that is the date in which we published our first data around race ethnicity in California. And I will tell you, it was incredibly important because we had reached a level that it was now clear that reporting the data would help us understand what was going on. The numbers were large enough, but it also really challenged us because we saw deficiencies in our data collection and really we're quite concerned and continue to work very hard on completing information around race ethnicity, which wasn't being reported consistently into our system. That's for both systems level issues, but also individual reporting demands of providers in the setting of a pandemic. We've made great advances on that, but I want to share with you what information we have and also really present this as the beginning of our understanding and really a call to us to do much more, which we are stepping up to and continue to do every single day related to this. So today we have 289,000 cases, 500,000 deaths to date, and are reporting about 100,000 tests per day. And that becomes important because that helps us really understand much more about who's being affected. The more tests that we're able to do, the better our understanding of how this is affecting everyone, and importantly, how this is affecting health inequities. Next slide, please. Next slide. I'm going to take a moment to orient you. Oh, go back one slide to this slide. There are three exactly the same, so stay with me for a moment. Across the left-hand side column, you'll see race ethnicity, and then the next two columns report on the number of cases and percent of cases. The next two columns report on the number of deaths and percent of total deaths. And finally, on the right-hand side is the percent represented by that population, that race ethnic group in California's population. So you're going to want to compare the far right column to the other columns to help you understand proportionally if a specific race ethnic group is being overrepresented by the number of cases or deaths or underrepresented. This data comes from slides were made yesterday, submitted yesterday, and what you see here, and this is for all of our cases, is that Latinos and Blacks light up in a couple of specific areas. Latinos with respect to cases, they are clearly overrepresent the number of cases with respect to the percent they represent in California's population, 54.9 compared to 38.9, and then also in the percent of deaths. When we look at Blacks, we see, interestingly, and this has been sustained over time, a lower percent of cases than what they represent in the population, but a higher percent in deaths. Now, when we first did this analysis across race ethnicity in April, on April 8th, there was actually no difference across any race ethnic group and the percent population. And so in April, what we did then was say, well, that could be, but we know enough about structural inequities and we know enough about these communities that let's look at this closer. So what we did is we started to break down and continue to do so every single day to stratify this by age, to understand if there are differences within age groups. Next slide, please. So this is one that I will show you for ages 18 to 34. Because of limited time, I'm not going to go through every single age cohort, but I want to point out here that you do start to see much greater differences, particularly if you look at African Americans. They have fewer cases, 3.8% of total cases, but the percent of deaths that they represent are 14.7% of all deaths. That's to be compared to the percent that they represent in California's population, which is only 6.5%. But Latinos, you'll also see across the board with both respect to percent of cases and percent of deaths, much higher percentages than they represent in the California's population. I'm going to talk about Native Hawaiian and Pacific Islanders because there's also some differences there, but I'm going to do it in a different format because they're a smaller population. We need to look at it a different way to really understand those disparities. Next slide, please. So that was 18 to 34 that I just showed you. And this is the ages greater than 80. I put this slide in here because I want to show two things. One is that the differences do persist, but they're not as great in the older ages. So there is something happening, particularly in the younger ages by race ethnicity, that is demonstrating these disparities in both cases and percent deaths for people of color in California. I'll also note that for Asians, the levels are roughly similar across and whites as well. In general, whites represent under their, the percent of cases and deaths is under their percent population overall as well. Next slide, please. Okay, this is a little bit of a different format, but it helps us understand something more about what's going on. This slide looks at incidence. So before I was just giving you this rates. This is the number of cases per 100,000 in the population. Across the horizontal, you'll see these are grouped by race ethnicity. So on the far left is African American, followed by American Indian, Asian, Latino, multi-race, Native Hawaiian and Pacific Islander, and white. And you'll see again the differences by age group. So a reminder, this is incidence. So ages 0 to 17 are gray. The gold color is 18 to 49. The blue color is 50 to 64, and the green is the greater than 65. So I'll draw your attention to these three groups that we're looking at with respect to disparities. So starting on the left-hand side with African Americans, you see that continued increase in incidence, but higher in group age 65, because there are many more cases in our older adults again in this age group. And then as we look at Latino, but then in particular Native Hawaiian and Pacific Islander, you see that even that because of the smaller numbers, looking at incidences instead, it really helps to unmask these really much higher incidences in the Native Hawaiian and Pacific Islander population compared with other race ethnicities. So another important way to look at it to understand disparities as they're occurring through the eyes of COVID-19. Next slide, please. Okay, so this slide, I want you to forget the colors that you saw before. They're representing different things in this slide. So this slide gives us a sense of change over time. So gray is March, April is gold, May is blue, and June is green. And now we are across the very bottom, you'll see race ethnicity, and we've split them into age groups. And this is incidence again. So what I want to draw your attention to here is what's happening in, let's start with the Latino population in the 0 to 18 age group. So in the upper left-hand group, so let's look at kids now. This is 0 to 17-year-olds. And that very center set of bars is going to be the Latino children or younger people between 0 and 17 years of age. This is important to look at because it helps us understand also over time the really important trend up that we're seeing with respect to incidence in race ethnicities. And what we've seen is this really ballooning numbers in Latino children. We also see them in the Native Hawaiian and Pacific Islanders over time as well. Now, it's not a surprise that one might see this sort of shifting over time because COVID-19 came in originally as a travel-related infection, and testing improved over time as well. So we're seeing it move and shift across populations, perhaps starting in one subgroup, but then moving into others because of the way in which it's moving in our community and because of the way in which we are working to control it across our state at large. So I want to pause here and make a comment about this, and that is the question of why is this happening in our communities of color? Well, I think, you know, the easy answer that many of us have worked in public health for a long time and know that there are really substantial structural inequities that have occurred over time and have accumulated over time to create disadvantage in these communities disproportionate to other communities. The results of that includes many negative impacts on the population, including higher rates of comorbidities that we also know are associated with COVID-19. But I would be remiss if not to say also, we also have to look at the way in which the state and all of us have been responding to COVID-19 in attempting to control its movement, in particular through measures like the stay-at-home order. So while the stay-at-home order is indeed to keep people from moving, we do have an essential workforce that continues to work. And that essential workforce is overrepresented by brown and Black people. And so as a result, we know that it is going to have higher rates of potential for exposure in certain subgroups over other subgroups because the essential workforce continues to work regardless of a stay-at-home order. Next slide, please.
Thank you, and Dr. Angel. This is Eric Douglas. I just want to remind you that we're at the 10-minute mark now.
Okay, and so when we look at this layering, we know that historically these communities, Black and Native Hawaiian Pacific Islanders, have already gone into COVID-19 with a disadvantage with respect to life expectancy, which is the product of all of what I've just described. Next slide, please. And when we look at comorbidities, we also see that communities of color, African Americans and Latinos also have higher rates of asthma, diabetes, heart disease, obesity, and high blood pressure. We know that these comorbidities increase the potential for poor outcomes, and we think that this is also driving the impacts that we're seeing in communities of color, in particular in Blacks. Next slide, please. So in the end, we know that COVID-19's health impact includes both the product of the direct and indirect. I've just discussed the indirect, which is the morbidity and deaths, but we can't forget also the indirect impact that it's going to have on these communities. And I think this is where your discussions become really key, which are related to preventive care delays, chronic disease managed delays that lead to uncontrolled diabetes, for example, mental health that goes unchecked and unaddressed, and the social risk exacerbation like economic instability, housing instability, social isolation, and domestic violence. And so all of those things, which we know as the social determinants of health, also play a part in this. Next slide, please. This slide shows us over time vaccinations in California, and it really helps to illustrate what's happened during the stay-at-home order. These are vaccinations in children between the ages of 0 to 17, and we've seen a 40% decrease in vaccinations this year compared with last year. So preventive care is absolutely being affected by COVID-19, and that impact will be enduring as we try to do catch-up. We will continue to maintain challenges with that. Next slide, please. So in order to address structural racism, the really key opportunity is for us to change the structures that perpetuate them. That is the way to do so. And I think in this moment in time, as we think about rebuilding structures, that's the opportunity that exists. Next slide, please. And I want to talk a little bit for just 1 minute about some really sort of imagining of how one really thinks about clinical care systems and public health systems and the relationships with one another. Because as you talk about financing that which is on the right, our clinical care systems, the opportunity to really synergize and have maximum impact really demands that public health systems are taken into account. And so when those redesigns occur, they're redesigned in a way that maximizes the impact on health that we all can have. So this slide depicts really when these systems, as they are largely now separate, it's really a fragmented experience for the individuals, and those who are at social disadvantage have an even greater time being able to access and benefit from any of these systems. Next slide. Next slide. And as we bring them together, these approaches, we start to see some improved impact. That's happening. A concrete example is the work that we're doing around ACEs, where we really screen and refer to services from the clinical care system into public health systems. But that really misses the huge advantage of truly integrating the way that we think about these systems. So next slide, please. So the power of integrating the approaches, not necessarily the systems altogether, but the approaches as they interface, is that one really can take advantage of the strengths of surveillance, of policy and programming that can affect entire communities. And when we do that in a very thoughtful way, and we use systems to do so, we can engineer out inequities that are in our system. And so just as a last slide, I want to show you, next slide, please. I want to show you this slide that comes from New York City because I haven't seen it repeated anywhere else. But we did this in our department when I was there in New York. And this reflects 1/4 of New York City's population. This hub population is from electronic health records, and it shows the distribution. The right is female, left is female. It's the population structure. And you'll see what on the care delivery system covering patients in primary care clinics across the city, that there's this big carve out on the left-hand side that is young males between the ages of 15 and 49. And so when we talk about access, and you'll see actually the population structure on the right-hand side, when you compare the two, you see that clearly these folks are not going to care. Now, this is very obvious, and I know your report really looks specifically at California to understand and who is uninsured in California. So there's many different ways we can talk about access to care. But I think one of the things that public health can bring to the table is an even deeper knowledge of this group. So as we looked more closely at this age group, for example, in New York, we knew that 10,000 New Yorkers, largely young Black males, are in jails every single day. These are people that are potentially being carved out of the system. So I think the question of access and care and equities is one that really deserves and benefits from bringing together these systems of public health and care delivery and thinking about, as you invest in unified financing to create a more comprehensive care delivery system, ways in which they incorporate understandings from population health, understandings from public health, in order to really more comprehensively address health inequities, now in COVID and beyond as well. Thank you. And that's it.
So Dr. Angel, this is Eric Douglas. Thank you so much for that presentation.
Welcome.
I wish we had time for questions, but really to keep us on track today, because we have such a jam-packed agenda, I do think it's important for us to turn to Dr. Richard Cronick. And Dr. Galley, I wonder whether you want to introduce Dr. Cronick's next presentation, or whether you want me to just give him the baton.
Yeah, for the sake of time, Dr. Cronick, go ahead and take it away.
Thank you so much. Thank you, Dr. Galley and Eric, and thank you, Dr. Angel, for that really informative presentation, which reminds us that as the Commission does its work over the next 6 months in providing advice to the legislature and the governor about how to implement a system of unified financing and coverage, that keeping front and center the question of how the advice that's provided, how the system that's being recommended will increase health equity, reduce disparities, that those questions need to be kept front and center. Commissioners, in 14 and a half minutes, you'll be going into breakout rooms and discussing how to do that. What are the features of a system of unified financing and coverage that will, in fact, move towards achieving these goals? I think we all know that getting everybody covered will help, but it will still be the case that the resources available to people in Southeast San Diego are different than those to people in La Jolla, at least on day one. And figuring out how to change that and how to create accountability for change is a key part of the problem. My job in the next 13 and a half minutes is to provide an introduction, a roadmap to what we will be doing together over the next 6 months in trying to provide advice to the legislature and the governor about what this system of unified financing and coverage should look like. I want to spend just a couple minutes and show you 3 slides, if we can go to the next slide, that are repeats from January, but January was a long time ago, and I know there may be some kind of question of what is unified financing and coverage. So I want to make sure we're all on the same page. Status quo, people get coverage for all kinds of different arrangements depending on how old we are and where we work and what our income is, and the kind of coverage we have affects our access to care and how much providers get paid. Unified financing and coverage on the right, we're all in the same boat. Next slide, please. What does being all on the same boat mean? We're all entitled to receive the same package of healthcare services, again, regardless of our age, employment status, other characteristics. And the distinctions among the programs we have now would be eliminated. Next slide, please. International examples show us that there are many different ways to implement unified financing and coverage. The single payer systems in Canada and Taiwan are one flavor in which the government makes direct payments to hospitals, physicians, and other healthcare providers. In the United Kingdom, publicly provided care, much more like the Veterans Administration in the United States, in which the government, the National Health Service, owns the hospitals, and most physicians are salaried employees. And then Germany and the Netherlands, quite different. Mandatory purchase of standardized insurance from nonprofit insurers. In all of these countries, everyone is pretty much in the same boat. And I think that that's the the defining feature of unified financing and coverage. And the job of the commissioners is or to provide advice about how to implement unified financing and coverage in California. Not likely to look like any of these particular models, although I can imagine might have features of each. Next slide, please. This slide shows the topics that you'll be dealing with over the next 6 months. Today, trying to figure out how unified financing and coverage can increase equity and improve quality of care. Eric Douglas will talk a little bit more about that before we go to the breakout groups. The subsequent slides, I have one slide on each of the other 5 meetings, so I'm not going to read through this now. Next slide, please. As background, each of the subsequent slides for each of those topic areas, and go backwards a little bit, you might say, why these topic areas? These are the areas that I think if you're designing a system of unified financing and coverage need to get dealt with. And the legislation tells the commission to deal with these areas. As you read any other legislation, you know, these are the areas that get dealt with. Why the order? We consulted with Drs. Galley and Chen, and there's nothing magic about the order, but we think that it will work. In each of the subsequent slides, on the left-hand side, we'll see how SB 562, the bill that I'm sure everyone here is familiar with, proposed to deal with decisions in these areas. And then on the right-hand side, we'll raise some questions and issues for discussion. This may be fraught because obviously SB 562, there's lots of intense work on both sides, and I can imagine that some people will say, I've mischaracterized SB 562, and others will say, why are you even starting with that? We're using it as a heuristic, as a sort of chassis for trying to understand the decisions that are coming, not implying either an endorsement or a critique of that bill. Next slide, please. In August, we'll talk with you about financing and ask you to provide some advice about how the $400 billion, more or less, for healthcare should be raised in California. Little bit of a kind of a funny thing here that we're going to be talking about financing before we know exactly how much money is needed. We will not yet have talked about provider payment or exactly what benefits are being covered. And without those things, person can't know, is it a little more than 400 billion or a little less? I think we'll be able to have a useful conversation on the premise that we'll need probably about as much money as we need now. Maybe it'll be a little more, maybe it'll be a little less, sort of a detail that doesn't matter for this level of discussion. SB 562 says very little about financing. It establishes a trust fund, directs the Healthy California Board to seek waivers, try to get the federal government to provide the money that would otherwise have been paid for Medicare and Medi-Cal and Affordable Care Act subsidies, and is silent about how non-federal revenue would be raised. Next month, we'll be asking you to consider questions starting with what principles should govern financing, talk a little bit about the potential barriers to getting the Medicare and Medi-Cal and ACA monies and options to overcome those barriers. Very little bit on this question about other federal programs and how that might be dealt with. Spend most of our time on the options for non-federal revenue sources. How might those funds be raised, as well as some consideration of options for creating and funding a reserve. Next slide, please. In September, how should hospitals and physicians and other healthcare providers be paid? SB 562 says that the Healthy California Board should negotiate with providers and that payment should be reasonable and sufficient to guarantee access. is otherwise silent on the level of payment, and does say that the default mechanism would be fee for service, although how the California board would have the authority to demonstrate, to experiment with other forms of payment, and as we'll talk about on the next slide, make capitated payments to integrated health systems. In the September meeting, we'll start with discussions of the pros and cons of having legislation that is quite open, just says, negotiate payment rates versus setting payment rates, which is, what we have done in Medicare and Medi-Cal and other programs. It's a bit hard for me to see how negotiation works in the context of a budget constraint, but there may be ways to make that work, but we'll present, pros and cons there. Ask you to provide your advice about what principles should govern provider payment, and we'll seed you with some possibilities. Discuss how the rate of change in payment rates over time should be determined, and then pros and cons of having the default being fee for service. Currently in California, about 60% of commercial and Medicare payments to medical groups is made through capitation. If that were to change to largely fee for service, it would clearly be a very big change. Next slide, please. In October, we'll ask you to consider whether there should be a role for intermediary organizations. SB 562 says that all Californians should have freedom of choice of any provider. It does say that Californians could enroll with an integrated healthcare delivery system, which could choose to be paid based on capitation, but not much about anything else about integrated delivery systems, and does certainly say that there's no role for health insurers for any benefits that are covered under the Health of California system. Important, I think, to consider questions about what are the functions that intermediary organizations perform currently. As I mentioned, 60% of payment to medical groups is through capitation. And as you move into the breakout groups today and wrestle with questions about how to increase equity and reduce disparities, the questions of what organizations, who's accountable for doing that will, I am sure, be front and center. And clearly the Health of California, whatever the governing agency, can be held accountable, but a pretty blunt instrument and hard to know exactly how to make that work. So I think the question of, what role, if any, should there be for intermediary organizations, and what does accountability look like there, will be very important. We'll consider those in October. Next slide, please. And then in November, a series of questions, I think maybe less contentious than what we will be dealing with in October. Eligibility, SB 562 says all California residents, pretty straightforward. I think probably everyone here would agree with that. There is then a question of how is residency to be defined. Maybe what the Department of Motor Vehicles does is good enough. I don't think, not proposing we spend much time on that. There are some questions about how do you know when someone is no longer a resident? I mean, clearly, any system of unified financing coverage would need to cover Californians when they're temporarily out of the state. But what does that mean? Again, I wouldn't propose spending a lot of commission time on that. We'll spend some time on the question of what benefits should be covered. SB 562 has a quite expansive list of benefits. At least some consideration, I think, should be given to the pros and cons of including particularly long-term care, potentially other benefits that are not currently typically covered by employer-sponsored insurance or Medicare. And then finally, in November, consideration of cost sharing. SB 562 is quite clear, no cost sharing for patients for any covered services. I think probably everybody here would agree that that makes sense, certainly for people who are currently eligible for Medi-Cal and other low-income Californians, whether it's makes sense and what the pros and cons are of having cost sharing for upper income Californians. We'll spend a little bit of time on in November. And then finally for this year, next slide please, in December, a series of questions on governance and cost containment. Here, SB 562 calls for the creation of a 9-member board appointed by the governor and the legislature, quite a bit of specifics about avoiding conflicts of interest and who can be on that board, is largely silent on actions that the board can take to manage healthcare spending, which is certainly an important responsibility for any governing body. Sort of starting question to consider, and you will, I'm sure, deal with some of this today in the breakout session, how to ensure that the governing body serves the public's interest and not providers' interests. We have a long history in the United States of regulatory bodies being captured by the people being regulated. We all know we're talking about a $400 billion industry here, lots of interest from people in that industry and trying to make sure that they are not harmed, and working at trying to make sure that all of this does increase health equity is an important question to consider. And then another kind of question around governance is what authorities does the governing body have to manage expenditures, what authorities remain with the legislature, and what authorities may remain with the federal government in whatever agreements are reached around turning over Medicare, Medi-Cal, and other federal financing to California. Next slide, please. So the summary is, I hope that you will think that SB 562 was a useful heuristic and a useful kind of starting point, and see that there are a variety of decisions that, or not decisions, but advice that you will be providing to the governor and the legislature about how to implement a system of unified financing and coverage. Over the next 6 months, we will be presenting analysis to you of options for these key design dimensions, and to the extent we can, analysis of the pros and cons of various options. I also invite you to provide your sense of any of the important questions that should be dealt with on financing or on provider payment, or the role, if any, for intermediary organizations, et cetera, so that we can be sure as we get to those presentations that we are addressing, in the slide, I've suggested questions that are top of mind, and others have thought are important, but we'll be interested in trying to make sure that we address your questions. So thank you very much, and I'll turn it back to Eric then for leading us into the breakout groups.
Thank you, Rick, very much, and thank you for that presentation. Before I get going with the breakout rooms, I do want to just acknowledge that we now have a full House of Commissioners. So Senator Pan has joined us, as well as Jenny Chin Hansen. So welcome, and thank you for being here. So as we move into the breakout discussions, I want to first just go through the protocols and how we're going to make this work. Commissioners will be automatically assigned. We've pre-assigned you to 3 breakout groups. So when we start the clock, that will happen automatically. Members of the public will also be assigned to the breakout rooms. That will be just a randomized process in which you get assigned to one of the 3 breakout rooms. Not to worry, if you're interested in what happens in the other 2, we are recording all of them, and you will have a chance to go back and, after this meeting is over, listen to the recordings once they are posted to the website. You will be able to observe the breakout room discussions, but you will be in listen-only mode. In terms of the facilitation in the breakout rooms, there will be both a content expert and a facilitator, although frankly, both of us will be facilitating in the breakout rooms. Each group will address the same questions. The consultant team will capture the input, and then we'll ask one commissioner to volunteer to be the spokesperson for your particular group to report out on the notes that we have captured we will be, as I say, taking video recordings of the breakout rooms so that we can post them to the website. So I'm going to set the clock at 25 minutes for the breakout sessions. So at this point, I'm going to share with you the discussion topics. What design elements should be included within unified financing to reduce disparities and increase equity? And then how could we tell if high quality care was being equitably delivered? What outcomes and indicators should we watch for and for whom? So those are the two questions we're going to be posing to you. At this point, if the host could move us all into the breakout rooms, we will see you there.
To create the levers to actually hold providers and the system accountable for improving quality, reducing health disparities, and dealing with many of the issues that was raised earlier by Dr. Angel's report. Thank you.
Thanks very much, Anthony. That was great. And obviously it was a very rich discussion, so great job. I'm going to turn now to group 3 while we're still waiting for Eric to see if he can return from group 1. And Marion, can you just help us with that? I think was Carmen, Commissioner Costi, the reporter for your group?
She was for, that is actually group 1, and Eric's got the notes, but I think we're in the same fix with either group. So although I promised Carmen she would have the notes, could you give it a try anyway?
Yeah, sure. So our group discussed, there was a discussion on opposing viewpoints about whether or not quality and equity, disparities in equity would be addressed best with shared risk pools and risk sharing. Some folks thought that that was a way to, that was a design element that should be included in unified financing. Others did not. Disclosure, I was the one who opposed it. Others were talking about ensuring that we had good data and transparency in the reporting and the information that we received on from a unified financing system. And I'm trying to remember. I'm sorry, guys.
I guess I might jump in and say that there was, I think, an expansive sense of a definition of health that went beyond some of the clinical indicators that maybe we most commonly rely on. Is that fair?
Yes, I think so, and I think there was a push to widen what we determine to be broader than outcomes. Although we did discuss what types of specific outcome measures would be good to be tracked. I'm trying to think of other folks that were in the group want to pitch in here. There was discussion about making sure that innovations and new healthcare funding was equitably distributed to underserved communities. And ensuring that there was equity in financing. I believe Mark was saying that. I think our discussion was really about trying to make sure that, to broaden what we're talking about when we're talking about equitable delivery and quality.
And Carmen, I finally.
Oh, there we go.
Just as you wrap up that.
I think we've probably made pretty good progress here. I think that one point that I recall was Sandra Hernandez around the distribution of the workforce and access to care, and then broadly there were comments around payments that did not disincent people who saw people with high health needs or special health care needs.
Great. And Carmen, thank you for doing that under challenging circumstances.
Absolutely.
That was very impressive. So let's turn to group 3. I guess this really is group 3. Karen, if you can maybe just put up your screen and tell us who the reporter is for your group.
Well, as poor luck would have it, Don Molds was sort of voluntold to be our volunteer, and then he froze. So I'm not sure where this landed and whether I can put someone else on the spot.
It looks like Don might have just been able to join,
But also
Don,
Janice agreed to
Janice, that's right.
Yeah.
Thank you so much, Janice. I'll just try to scroll slowly and follow you and how you want to just summarize this in a few minutes.
Okay. Yeah, I don't think Dawn's going to fight me for this opportunity. In any case, so, you know, the discussion did start off with the goal of some of eliminating private insurance from the system. And we talked about making sure people get the right care at the right place at the right time. You know, more care is not always the right way to go, depending upon the needs of the patient. And we talked about the current system, you know, is ripe with inequities. And so in creating the new system, keeping in mind what some of those are. We talked a little bit about access to care, full range of services that go beyond medical services, and like health education. We talked a bit about the healthcare workforce and the need to build the workforce, and just general equity overall in terms of you know, covering everybody with uniform benefits.
Thank you. Nicely done, Janice.
Thank you, Janice.
So Andy, if I can just jump in, this is Eric again. I think we're at the point where, if I'm assuming correctly, since I was dark for just a bit, that you've gone through each of the 3 breakout groups. Andy, would you take a moment and just summarize kind of from your own perspective, kind of what you've heard so far, as well as how you see it tying in and connecting to the future sessions of the commission?
Yeah, okay. I guess the first thing I should say is flying between breakout rooms can be dangerous, and I'm glad most people made it back, but hopefully no one was injured too badly along the way. Thank you all. I actually thought it was amazing. I really valued being in the breakout room with a smaller group of the commissioners and seeing the interaction. I thought the quality of the suggestions that have been raised and the degree of interaction, not only judging from my own group, but from the report outs, is really a powerful and valuable thing. I found it really affirming to hear such strong support for the value of equity at the time that our country is engaged, actively engaged, and reconsidering how our policies across the board support or undermine that goal. And, you know, I think the discussion we had here today serves as a reminder that universality is going to be foundational to equity. Anthony Wright said that in our group, but it's not going to be sufficient. And in the months ahead, we are going to be taking a deep dive into key design features of unified financing, as were described earlier today by my colleague, Dr. Cronick. And, you know, we hope that in these discussions we have about these different design features, that you'll use each of the values associated with this commission and its work. So equitable care, accessibility, affordability, high quality, and universality as a way to kind of evaluate and consider the different design features. So for example, when we discuss healthcare financing and the generation of revenue, you should consider how the various options might interact with the value of equity. As some ways, as were pointed out, may disproportionately impact some members of society more than others. Similarly, when we talk about provider payments, you should think about what is the approach that will best promote the value of equity. Is it relying on the same payments for all patients, or should perhaps the payments be higher if the patient has a higher level of social needs? That is the opposite of what happens now. Similarly, when we talk about the role of intermediaries, you should consider whether accountability for equity and other values of this commission will best be served by having them managed centrally by the state or through some intermediaries such as a medical group or health plan. Equity, you know, was the focus today, but we encourage you to think about each value and hold it up as a lens by which to assess and debate the various design options of unified financing. I'm super encouraged by your contributions today and know that the state of California will benefit from each of your contributions as we work together to design the best model of unified financing of healthcare for our state. So thank you very much, and back to you, Eric.
Thank you, Andy. Well, I'm going to, at this point, open it up for public comment and turn to my colleague, Karen Bloomer, to facilitate 15 minutes worth of public comment before we resume the agenda at 5 o'clock with the community engagement process.
Thank you, Eric. Yeah, so at this time, what we will do is for looking for public comment, we will ask members of the public to click on the participant icon and then find the participant panel and use the raise hand feature to line up, and we'll take as many comments as we can in the time we have. But in order to do that, we ask that those commenting use a 1 minute mark for their comments. So just very briefly, I'll give you a 5-second notice when you're almost at that 60-second mark so we can move on and hear from others. So I'm going to work with Aaron Matlin on this. So we're going to turn to Francis Lee and invite Francis to unmute and give us no more than 60 seconds of comment. Thank you.
Hi, my name is Francis Lee. I'm an at-large delegate to the California Democratic National Convention for California. I just wanted to point out that the environmental analysis report published at the previous meeting seemed to rely on a lot of data coming from studies analyzing costs in 2014. And there have been a number of more recent studies, for example, published in January of this year in the Annals of Internal Medicine, analyzing costs in 2017 showing $800 billion a year in administrative overhead for healthcare, of which over $200 billion a year attributed directly to private insurance billing overhead. So it seems hard to believe that a mixed model of private and public options can be a solution to control our out of control spending costs. I think this is a strong argument in favor of single payer coverage. Thank you.
5 seconds. Thank you so much. Hal Goldfarb, we'll invite you to unmute, and if you do have an affiliation, please let us know as well. Thank you.
No affiliation, I'm just a public citizen, but I've been interested in single payer for a number of years. And what I want to know is what is different about this moment in history that is different from all the previous moments in history when we've been fighting for single payer in this country since at least the 70s. At least PNHP goes back that far. How are we going to get single payer when we have a political party supposed to be representing the people, supposedly the People's Party, that stands in the way of us getting single payer? Many of the Democrats are on payroll with these companies. I mean, not payroll, but you know what I mean, payola, okay? So I don't see how this is going to happen. Strategy has to include the politics of this. It can't just be a bunch of you sitting on a board and telling us all about the wonders of single
5
payer
seconds.
and how much money it'll save. We know that. I'm putting the question. I'm asking the question. That's not rhetorical. Thank you.
Thank you. And we will just be taking comment and aren't in a position to respond at this time, but thank you for your comments. Perry Briskin, we're going to invite you to unmute.
Hi, everyone. My name is Perry Briskin. I'm an MBA MPH student at UC Berkeley and also a head steward with our Student Workers Union, UAW 2865, representing 19,000 academic student employees across the state. And we are here, UAW 2865, to also put our support for single payer. And also just to address from a student population perspective, we had a lot of graduate students graduate without jobs that they were expecting, and that's left a lot of people uninsured, unemployed, and without a lot of options. And thankfully, we have covered California, but I think this calls for a decoupling of insurance from employment, and then where do we go from there to go from single payer? So the students are with you, we support it, and thank you for all being here today.
Thank you very much. And Gina, you're up next. If you could give us your full name, please. Thank you. Inviting Gina, the RN, to unmute.
Okay.
There you go.
Can you hear me now?
Yes,
Oh,
yes. Hello.
Okay. Hi, I'm Gina Harris. I'm a nurse. I'm also a state delegate to the party. I'm also a LACDP member, so very involved in party politics. But I also represent a payer. So I work with shared risk. I work with full risk. I'm mostly representative of a full risk group. And let me tell you, it is not working. The administrative costs are very costly. While it still pays me, I still advocate for a single payer system because I know what I'm doing right now is not going to actually lead to a better healthcare system. So I'm just basically putting this out there that you're going to come to a gap where the data is not going to completely answer all your questions. And then, you know, maybe if you want to talk to someone like me who's advocating for completely opposite of what I represent, like going to take a six-figure salary out of my own pocket if this passes, I would like to do that because I know that this is the road we need to go. So it's going to eventually be a leap of faith. And I'm telling you that we need to do it before the next pandemic happens. So that's all I wanted to say. Please reach out. I would love to get my comments.
Thank you very much. Thank you. Thank you so much. Lynn Silver, we invite you to unmute. Go ahead. Oh, you're muted again, Lynn. Can you unmute? There you go.
Thank you. Lynn Silver, Dr. Lynn Silver, I'm a pediatrician at the Public Health Institute, and I co-chair the California Alliance for Prevention Funding. So first, I salute the commission for its work. I hope that you come up with a brilliant proposal for a universal, progressively financed coverage of our entire population, and one that's less complex, harmful, dangerous, and unfair. That said, I'm here to speak to a specific point which Dr. Angel started to address. Every article in the paper for the last 4 months has decried how for decades we have disinvested in our public health system and failed to prevent the risk factors and the diseases that are now contributing to making COVID so devastating. We cannot punt that down the line for another 20 or 30 years. As you seek to develop financing and coverage design for the 21st century, we need to include a component of community-based prevention and addressing health equity together with the funding streams to support individual coverage. Only in that way can we truly promote health equity. Thank you.
Thank you, Dr. Silver. Reggie Wong, we invite you to unmute, 60 seconds.
Reggie Wong, I am a delegate, district delegate for CD33 for the DNC, as well as a member of DSA LA. I've had friends who were fully employed, and yet their employment did not provide health insurance. One of them passed away from cancer. So it kind of shows that you can't rely on employers to provide you health insurance. And in case you didn't notice, we are in a pandemic. You want to stop the spread of this disease, make sure everybody is able to get treatment if they get sick, or get that vaccine when it comes out, because the coronavirus is not going to check your credit score before it infects you. Thank you. Yes.
Thank you very much. Thank you, Reggie Wong. Appreciate that. Peter Shapiro, you're up next, if you'd like to unmute.
Hospitals have become an increasingly popular outlet for private investment, and investors seek out markets that promise the greatest return. This is one reason why rural hospitals are closing and why healthcare inequities are as rampant as they are. Something like 70% of California's public funds appropriated for healthcare are channeled through private entities. A direct public financing would free up dollars that would address the full range of social determinants of healthcare. And I think that's the best way to approach that particular problem. Thanks.
Thank you so much. Robert Vinetz, you're invited to unmute.
Unmuted. Hi. Thank you very much for the opportunity to speak. I'm Robert Vinetz, a retired primary care pediatrician, including 3 years with the Los Angeles County Department of Public Health. I'm now associated with California Physicians Alliance and its roadmap to universal care. I would like to call your attention to my written submission, a graphic checklist tool for evaluating various healthcare system proposals. The aim of the tool is to visualize at a glance graphically how well any proposal meets the goals of the commission and/or of an optimal quote-unquote healthcare system.
5 seconds.
I hope and believe that the graphic checklist can be a tool of value as the commission pursues its work. I urge and hope you will be able to examine the tool, and please feel free to edit, adapt, and use it in any way that you might find helpful.
Thank you, Dr. Vaness. We're going to need to move on.
An example of it.
Thank you.
Yeah.
Thank you so much. Carolyn Sanders, we invite you to unmute.
Hi, can you hear me?
Yes.
Great, thank you. I just want to thank, I'm Carrie Sanders of the California Pan-Ethnic Health Network. Really appreciate the conversation today. Very excited to see equity being prioritized in the discussion and the talk about engaging diverse communities in, to get a better sense of their experiences in designing the system. One of the things, I listened in on one of the groups and, really interesting conversations. I think for us, we really feel strongly that equity must be a central component of all design and payment structures. So we're happy to see it being discussed here today, and want to, hope to see it integrated into all of the discussions that you have as you're walking through design of this of single payer or of a universal system. We also want to ensure that it's patient-centered, that the system is centered, and funds prevention, public health, and the social determinants of health, as well as workforce diversity. Thank you.
Thank you so much, Ms. Sanders. Jeffrey Tartagia, we invite you to unmute. Jeffrey, can you unmute?
Yes, Jeffrey Tartagia. CARA, California Alliance of Retired Americans. Yes, pushing for single payer. Yes, I hope that you will explain the reason why the California is going from the waiver of 1915 to C to 1915I. I think it has an impact next year, and I think this commission needs to understand what the state of California is wanting to do. At the same time, I will suggest that the federal model for community service, back to your community services, may do a means of dealing with a more equitable situation for the future. And that's my comments.
Thank you so much. Shelby Warren, we invite you to unmute.
Hi all, my name is Shelby Warren. I'm a second-year medical student at UC San Diego, part of the Prime Health Equity Program. I'm specifically commenting on something you could do to incorporate into a design element for racial equity. My suggestion is that I additionally support single payer. Just wanted to make that known. But this commission needs to deliberately and actively address systemic racism and white supremacy in all of its forms. Just as a reference, in the 2016 to 2017 year, 90% of the Congress was white, 96% of governors were white, 100% of the top military advisors were white, etc. Thus, this commission must actively address white supremacy, as I said, in all of its forms, including overrepresentation. Please, commission, get active about educating yourself about systemic racism if you have not done so already or do not come from an experience of racism. And please design this into your model, striving to gain expertise from scholars and leaders and your colleagues of color, and listen intently so that we do not continue to see the major inequities that we're seeing. Thank you.
Thank you very much. Kate Baker, we invite you to unmute.
Hi, I'm a citizen. I'm not involved with any particular organization. I just wanted to echo what Ms. Briskin said earlier. I'm currently a student, and I would appreciate and love the security of having healthcare detached from my job so I would have more freedom. And during this pandemic, we've seen unemployment rates skyrocket, and many have lost access to healthcare and other necessities. And I read this very interesting study about how a single-payer system could prevent job lock while promoting small businesses. I think that would be crucial during these times. And I also really appreciate the discussions that are going on in this meeting. Yeah, thank you.
Thank you very much. Appreciate it. We are at 5 o'clock when we need to move on to the next agenda item. We do see that obviously there are many raised hands. We will be inviting verbal public comment again at roughly the last half hour of the meeting. So we will pick up then. And of course, you continue to have the opportunity to provide public comment in writing via the chat feature today or via email at healthycaforall@chhs.ca.gov. All right. I will ask Eric Douglas whether we will be moving to the community engagement.
Yes,
agenda
so
next.
thank you, Karen. So we do want to move on next to talk about the community engagement process. Alice Chen, I don't know if you want to do a quick intro here of the next segment, or if we should just move right on to Bobby Wunsch's presentation.
Yeah, I just wanted to relay Secretary Galley's regrets. He got pulled into a meeting with the governor, so I'm going to take over from him from here. And just wanted to say a couple words to preface Bobby's presentation about community engagement. One is that we really appreciated the feedback from the commission last time. It really resonated with us and caused us to pause and pivot to really think about how do we prioritize engaging Californians and consumers. We've worked with our consultants to create a process that you'll hear about that really is intended to amplify the voices of Californians, particularly those that are most impacted by what a lot of people have already commented about, disparities, economic disparities, structural racism, all the things that have led to what we're seeing now with COVID. I also just want to acknowledge that we have several commissioners who have spent much of their careers and have deep expertise in community engagement and kind of lifting consumer voices. And we definitely welcome all the commissioners, but particularly those who have spent a lot of their careers thinking and acting on this to help us develop and refine this plan. So with that, I'll turn it over to Bobby. Thanks so much.
Thanks, Alice, and thank you all. I'm pleased to present a proposed process for community engagement and stakeholder input. If we can go to the next slide. This process that we're proposing today, and we'll look forward to the commissioner's feedback on, will be part of the advisory process that's identified in the statute that created the Healthy California for All Commission. And so today I'd like to focus particularly on two major areas: a process for engaging diverse communities all over the state, and a stakeholder input process from knowledgeable individuals who have worked much of their career in advocating for equitable healthcare. The next slide. So this is what I want to review in terms of the community engagement process. We'll talk about the process, the timeline, what these geographic areas are, an idea for using local community organizations to co-host these efforts, who the participants and what the content of the sessions might be, and then how we will report back to the commission at each subsequent meeting. Next slide, please. From our perspective, and I hope from yours also, the purpose of the community engagement component of this proposal is to reach out to every corner of California, to the diverse racial and ethnic and economic communities throughout the state, to listen and learn from a broad array of California residents what their perspectives are on how the issues that the commission is thinking about and studying and proposing will affect them, and to provide a feedback opportunity for the commission to hear from those perspectives and those communities and those individuals. Next slide. So far, we have only come up with a proposal. We haven't started the initial planning because we want to hear from the commissioners, but we are certainly ready to hit the ground tomorrow to start planning and implementing this process. What we're proposing is a series of sessions, 2 sets of sessions in 7 geographic locations around the state, so 14 sessions. They would be done because of COVID through Zoom for 2 hours. And we would invite up to 25 community residents and leaders of community-based organizations to participate in these sessions. The first series would happen sometime between July 15th and August 18th, or the end of August. The second series would happen in the late fall. And each of these series would accommodate issues that the commission is going to be undertaking so that you could hear back from communities all over the state on the issues and topics that you'll be deliberating on. All of the sessions will be open to the public and have a public comment period of 30 minutes at the end of each session. And we would welcome commissioners to attend these sessions when and how your schedules would allow. The next slide, please. So these are the 7 targeted regions that we have identified in which to have these learning and listening sessions. This is both a rural focus in any number of these regions as well as an urban focus. And we've identified which counties would fit into each of these regions so that we can have good representation across most of the counties in the state. Next slide, please. We propose on engaging a local community organization or a local community coalition to co-host with us these community meetings. We have not reached out to any individual community organizations yet because we wanted to get feedback from the commission, but these community organizations would be organizations that are recognized in their region to have experience bringing community residents, particularly low-income residents, together to talk about issues related to health. Each co-hosting organization would help us recruit participants who would be both community residents as well as leaders of community organizations, co-facilitate the meetings, and their organizations would help provide technical support and interpretation services to the participants so that everyone who's participating would be able to participate fully. The Health and Human Services Agency had reached out several months ago to the California Endowment, who's well known across the state for working with community-based organizations, coalitions, and community residents on equity issues and on healthcare for all, to see if the California Endowment would help support this effort and help us identify the most appropriate community organizations to help get these meetings going with us. And so the California Endowment has offered to do that and has also offered to provide a small grant to the individual community organizations so that they could help us support these efforts, and also could provide a small stipend to community residents who do not represent community organizations so that they can participate. We would ask each of the participants who's invited to participate to try to attend both sessions, both a session in Series 1 and a session in Series 2 in their community, in order to have some consistency during the conversations, but that would not be a requirement or essential. All of the participants and all of the co-hosting organizations would receive a short orientation on the Commission's work as some background for the questions that and the discussion that we would have. And we assume that most of the meetings would be held in the evenings or on weekends to accommodate people's work schedules. Next slide, please. As I mentioned, we're hoping to have up to 25 individuals per session, so that could be up to 350 or 400 individuals across the 7 locations, recruiting from communities of color, from underserved communities, from youth groups, wanting to make sure that the groups are diverse: Medicare recipients, Medi-Cal recipients, people who have covered California, people who've lost their insurance due to unemployment, and people who have no insurance due to their immigration status. And as I said earlier, each series will have a similar set of questions that will feed back to the commissions for the topics that you all are discussing. Next slide, please. This is a sample, just an example of some of the questions that might be asked at the first series, which will be done in July and August if this process goes forward, just to give you an idea. On the next slide, you'll see examples of some questions that might be asked at the second series of discussions across the state. Next slide, please. So in addition to the community engagement, 14 sessions in the communities across the state, we'd also like to propose 3 sessions of key stakeholders with approximately 25 organizational representatives in each of the 3 sessions. Again, we'd like a consistent array of people so the conversation one could build upon the next. The participants in these stakeholder sessions would include statewide health advocacy organizations, labor groups, the single payer advocates, and representatives of the single payer coalitions. The timeline would be a session in late July, early August, another session in the early fall, and another session in the late November, December window. And we would expect that, again, for these groups, they would last for 2 hours. There would be the public and the commissioners would be invited, and there would be public comment at each of the sessions. Next slide, please. And perhaps most importantly, we'd like to provide 2 mechanisms to give feedback to the commission and to the public. One, through a written summary of each series, so a compilation of the numbers of attendees at the locations, the demographics of the attendees, the questions that were posed at each session, and a summary of the feedback that the individuals participating gave. This would be sent to the commission and posted publicly in advance of the meeting. And then we'd like to invite, if the commissioners agree, 2 to 3 of the community leaders who co-hosted these sessions to come to the commission meeting and highlight the voices of the people in their communities and bring directly to the commission the perspectives of the communities across the state, so that you just don't see a written report, but you do hear a verbal reflection of these issues that are important across the state, and you get a chance to ask questions of these community leaders. Next slide, please. So I will stop now and welcome comment from the commissioners on any of the issues that I've raised, and certainly welcome your input. Thank you.
So thank you very much, Bobby. This is Eric again. So we would welcome about 10 or 15 minutes worth of discussion from the commission on this engagement plan. I'd like to encourage you to both think about what you appreciate about it, what you like about this plan, and communicate that, as well as any thoughts on potentially improving the plan. So please think about both those aspects of feedback. We'll use the yes button again on your screen to signify whether you wish to speak. So that will be the way for you to, quote, raise your hand and let us know if you want to make a comment about this engagement plan.
So again, very quickly, this would be using your participant icon at the bottom of your Zoom screen. And then when that participant panel pops up, you'll see the yes check mark. Although I do see, we'll be looking for other symbols as well, but that's easiest for us if you can find it.
So let's start with Janice Rocco. I think you had your hand up first, and then we'll have Jenny Chin Hansen as well.
I appreciate the desire to have a community engagement process and to have regional discussions as well as stakeholder discussions. I do think that with the regional process, where some of the participants might be less familiar with the commission and the goal of developing a unified financing system and, you know, accessibility, affordability, equity, quality, universality, those things that we are focused on, that the background that we give them is important, and the questions we ask them are important. The questions that, you know, popped up on the screen that were in the materials that we received yesterday didn't strike me as necessarily for the first session. The questions for the first session didn't strike me as necessarily ones that would elicit quite what we need in terms of responses to help us in the work that we're doing. So I just would ask that some additional time be spent to make sure that we're asking the most important questions when we bring people together in these forums.
And Janice, if I could ask you to email either anybody on this team, whether it's Dr. Ghali or Dr. Chen or one of the consulting team members, your thoughts on the specific questions, that would be most helpful.
Okay, thank you.
Jenny Shin Hansen, would you please go next?
Yes, I didn't realize I accidentally tapped that, but I do have a comment. First and foremost, thank you very much for making the arrangement possible. Heeding the input that we received at our first meeting about assuring that we have the voice of the public directly. I'd have just one comment. I think the process itself is broad and good, both in terms of getting the voice of people who are affected. But the question, I was going to make a comment about the question as well. In some ways, I saw one of the slides asking people about what they thought about the structure of it. And I wonder if we could turn it around and make it more person-centric to people were asking about their opinion on what would make their ability to receive the care they need more from their eyes rather than the fact of we think about a governmental structure. And in some cases, people will say that, but I think if we turn it more as to what's meaningful for them, what matters to them, to have questions really posed from their voice, their perspective, what would make their life feel like it was safer and that they could get the care they need. So I just would shift it from an institutional type of question to a person-centered question. Thank you.
Thank you for that feedback. So we have both Carmen Komsky next and then Peter Lee next after that. Carmen?
Yeah, so I want to make two broad comments on the community engagement piece. One, and I'm seeing this a lot in the comments here, that a lot of people seem concerned about, and I'm concerned about the way that, who are these co-hosts? How are they being selected? How is the California Endowment chosen to give grants to co-hosts? It's very disconcerting as to how this was put together. And just so, again, so folks know, the commissioners only saw this proposal a few days ago when it was published on the Healthy California for All Commission website. So, I wasn't talked to, we weren't really consulted about this, and I'm not entirely sure how the California Endowment was chosen, and I want to make sure that influences from insurers and providers who may lose out on a single payer system, or that they aren't influencing the co-hosts who are promoting these community engagement processes and how they're actually selecting the participants. Your plan says that these forums, or whatever you want to call them, are going to start next week. So, I don't understand the process of selecting the co-hosts and the individuals. It really seems to me that this is a California Endowment project and not a commission project. And then on the substance of the sessions themselves, I do question the framing, particularly of the second series. The questions that as posed, and I will send the consulting team my ideas about how the questions should be posed, but we're setting it up so that that the participants will have negative responses. We're asking them what are they worried about losing? I think we really, I agree with Jenny that we need to be asking about, we need to be more directly asking, what would make it so that healthcare is more affordable for you? Would eliminating cost sharing be helpful for you? Those are the discussions that would be helpful for the commission when we're talking about what are the elements that we need to include in unified financing. I'll leave it there. I will send you I have a lot of ideas about what should be asked instead of the questions that were posed. And if you could answer the questions about how the actual participants are going to be chosen and the co-hosts are going to be chosen would be very helpful and informative.
Mm-hmm. Thank you, Carmen. And I do want to underscore that, as Bobby Wunsch said, this is a draft plan. This is not in stone by any means. And this is actually the opportunity for the commission to give feedback, and we are listening intently to your feedback. Peter Lee,
Eric, I just want to point after Peter Lee, we also have Senator Pan and Antonia Hernandez.
Yep, thank you.
Thank you.
Great. Thanks very much. Two things. One, getting a broad set of information to inform us, I think it makes a lot of sense. I guess I've got a number of thoughts about this, but the one thing that whatever we do on this engagement, it's going to be a small slice of a very diverse state. And one of the things I'd ask for the commission to help us with is, for instance, I know, and I don't want to just pander to Sandra Hernandez, but California Healthcare Foundation did some really good surveying of California's experience with the pandemic that was looking at race, ethnicity, that looked at who's on the front lines of service, et cetera. And so I would ask if the commission staff can think about what are, in the last 2 years, statewide surveys that get at issues of where are barriers of service, what are those barriers. We've got a lot of good data out there about where cost sharing is a barrier. How's that carve out? And so I'd ask us to do something like this, but not think that's the end picture. The second is the idea of getting out around the state is great. I like very much the concept of oversampling communities of color, low income, underserved, but we are creating a system that's going to be a new system, we hope, for every Californian. So we better have a cross section of Californians, people with employer-based coverage, people with, and so the focus shouldn't just be on, everyone's going to be in a new system. So what's the mix of people that are recruited in to reflect the diversity in all ways of Californians? This is, I understand these participant sessions isn't the opportunity for advocates to be coming in, it's hearing from the cross section of Californians. So that's a challenge for the sponsoring groups to get that real cross section. Thank you.
Thank you. Senator Pan.
Well, thank you. I mean, I actually want to second a lot of things that Peter Lee just said. So we're, even with the number of groups and how many we're having, that still represents a fairly small slice of a very large, diverse state. I think you need to be sure you try to figure out how do you get that diversity of opinion that's out there, that's reflective of a lot of people's different circumstances. I think, one group I want to be sure are represented, and it's always a challenge, is people with chronic conditions or people with children with chronic conditions, because oftentimes they are less likely to be able to participate. I guess as a Zoom, maybe it's a little easier to have to physically go somewhere. So because people who are actually higher utilizers of the healthcare system, they're the ones who tend to run into more of the challenges as well. So you can get someone who's fairly well and they're just looking at the cost part, but if you really want to look at the value piece, but you do, and I am a little concerned that I hear people saying, well, we don't want certain people in there, but I think again, you want to try to get a cross section of people who represent a variety of who have different levels of engagement in the system. I think one challenge is going to be is that, I mean, we're going to have different advocacy groups, so we can talk about providers, insurers, but we have other groups as well who may try to lobby to get people in there. And I think, if we're trying to actually capture the patient experience, then we need to get patients, real, people and their family members who are not because they have a relationship with some organization or another. I think that's going to be a bit of a challenge to figure out how to do that. So, so I think there are some questions about exactly like which community organizations are hosting and how they're finding the people that they're finding. Is it because they're talking to people they already know and have existing relationships with? Or are they really trying to get it's not really a sample, this isn't a poll, this is a focus group essentially. So we have to also recognize that this is not necessarily, this is in many ways, how do we create a focus group, a set of focus groups that will be informative to the commission and not just tell us what some of us want to hear.
Thank you, Senator Pan. And again, let me encourage every commissioner who has thoughts to email them to Dr. Chen or to our consulting team. We are very eager to hear them. Antonia Hernandez, I believe you are next, and then Sarah Flox, you are up after her.
Well, I just want to commend the staff who put together the outreach, and I do agree with everything that has been said, and that is that community engagement is just one vehicle for getting input from certain individuals, and I think that the broader the outreach, the better. So the plan looks good to me. I would say, as to questions. Having worked with the California Endowment and understanding that it was the staff who went to the California Endowment, to help with this outreach, I think was a very smart thing. It's a major health foundation. It has access and relationships with the broad spectrum of the health industry. And so I would assume and have the confidence that they're going to reach out to a broad sector of the community. We have very limited time. We're on a very tight schedule. We have the experts that are providing us with the information. We're going to hear from the insurers. We're going to hear from the medical profession. So I think that to put this in context, it is an outreach effort to hear from the public. We're a state of 40 million, so we're not going to hear from everyone. We just have to make sure that every voice gets heard during these hearings. So I'm very pleased with the outcome. And yes, we need to worry about the way we ask the questions, what questions we ask, make sure that it's a diverse group of people so that we hear all voices. But I think it's a plan that's very well thought out.
Thank you very much. Sarah Fox, you're up next, and then I believe I don't see any other hands up at that point. And
Eric,
so,
this is Sandra. I'd appreciate a chance to weigh in here.
okay, you bet, Sandra.
Myself too. I can't raise my hand. I don't know why. This is Rupa.
Okay, Rupa, thank you. So we'll get both of you after we hear from Sarah Fox. Thank you.
Thank you. I just wanted to echo a lot of what has been said, but focus specifically on the community engagement sample questions, following up on what Carmen said. I appreciate the community engagement. The way I recall it is that at the last commission meeting, it was raised that the stakeholder groups were exclusively industry and employers. And I believe it was Dr. Ross that said, we need to look at, if we want to have a system that's equitable, we need to go to the communities that are most impacted and understand what is their experience of our current system. This was in context of the scan of our existing system. And so I appreciate that there's a community engagement process, but I was a little startled and disturbed by the sample questions too on page 33 of the PowerPoint, because that really goes, as Dr. Pan said, from being a focus group to being a poll. It really felt like they do feel like push questions. And I think the more important data that we need to gather is, what is the experience of the system? Where are these inequities in the system? How are they experienced by the people who are experiencing them? And be able to hear those stories in a more free-flowing way. And so I'm going to email some suggestions on the sample questions, but I do think it is incredibly important how these groups are structured and facilitated, because this is the foundation of our healthcare system. The people who are left out there that are not getting the right care. And so this is a critical process. I appreciate that it's happening, but the sample questions are, I think, off in terms of the goal that we talked about at the last commission meeting.
Thank you. Thank you, Sarah. So Sandra Hernandez.
Yeah, thank you, Eric. I want to thank the team. I think they've leaned into this notion of how do we begin to really get genuine community engagement into our deliberations. I have three thoughts. One is, anytime you ask an organization, nonprofit organization, to host a convening like this, there are costs associated with it. And so I think it's well thought out that they be appropriately compensated to be able to do that, whether that's through the state budget or through the endowment. I think that's a very important step to take. The second point is, I think we have an industry of healthcare, plans, providers, hospitals, advocates, et cetera. In the moment that we are in, I would encourage us as we think about what kind of organizations to outreach to, that we think about food banks, for example, that we think about organizations that are serving unsheltered people, that we think about organizations that are serving people who are reentering from the criminal justice system. So if we're going to think about social determinants of health and we're going to think about health equity, I think we need to overbalance as we think about what organizations we go to co-sponsor these engagement efforts. All the health advocate organizations have access to us, the plans have access to us, the hospitals, the providers, they'll get to us. If we really want the point of view of people who are least served, we should really think out of the box about what kind of organizations we should tap to do this work. And lastly, I would second what's been said by others. I don't think the questions are quite right. I'll take that offline and give you some feedback accordingly.
Thank you very much. And then Rupa, please.
Thank you so much for focusing on this community engagement piece and for all the work that our consultants have done. I just want to echo, first of all, just a slight discomfort, even though California Endowment does amazing work and they work with a lot of amazing groups and they have a track record of excellent work in the area of racial equity. It does feel a little uncomfortable to me that one of our commissioners, one of our voting commissioners, is the CEO of that group. It just feels like there maybe should be some distance between a voting member and this process of gaining input from groups. I'm also concerned about those people in communities that I serve that aren't part of a CBO. They're not part of an organizing group that goes and gets funding, that might have relationship with TCE, that might have relationships with more of these organized structures. So these are the folks out on the fringe and the margins who really, if we want to centralize equity, we need to be trying to reach out to these communities in as many different ways. And I spoke with Dr. Chen earlier today about the possibility of doing maybe a couple more public forums, a way to complement maybe these groups. I also would love to have transparency in the process of which groups are picked. So we all know who's being picked, who's developing these questions. Can we approve these questions before the focus group goes out? So those are just things that I am concerned about. I think that because most people on this commission are not of marginalized groups, I think it's really important that we really bring those voices really to bear on what we're doing here. Thank you so much.
Thank you very much, Rupa. So thank you, commissioners, for those thoughts and that feedback. And of course, as I've said already, we are still very curious to hear from every commissioner your thoughts about this engagement plan. I do want to toss it back to Alice Chen just to kind of wrap up this part of the conversation before we move on to more public comment.
Thank you, Eric. And I just wanted to echo Bobby and Eric saying that this is exactly why we wanted to bring it to the commissioners. And I just will acknowledge, I've seen a lot of the comments, you know, we are getting restarted with the commission's work. People are really eager to get into the details and the meat of it, as are we. I think this was actually an example of really being able to tap into the broad expertise and perspectives of our commissioners. I wish that the state had the funding and the nimbleness to actually engage as deeply as we want to with Californians across the state on the timeline that we need to. We are grateful to the California Endowment. Rupa, I hear you loud and clear. I will say that for many of you who have worked with the endowment, they are uniquely situated given their both genesis and focus and track record over the years in engaging with underserved communities. With that said, Dr. Ross is a commissioner, and we have had a commitment from the endowment that he's not involved in any of this process. He won't be hearing anything that the other commissioners won't. He'll be receiving the feedback and the information at the same time as the rest of the commissioners. So I just want to assure people of that. I do think that I think the feedback in particular around the questions, clearly we need to revisit those. I think Sarah was the one who talked about also the structure of the meetings is really critical. I think all of that is open for, and I would speak for Bobby, I think that we really welcome people's best thinking about how to do this. And then I think a couple of you raised, Sandra and Rupa, about who we reach out to is really important. And I really think that while this does affect every Californian, not every Californian is equally heard. And I think we do owe it to kind of weight the scales to people who traditionally don't have their voices in these conversations, and acknowledge that, that we need to find ways to tap into a broader perspective, including through surveys and existing data that's already out there from a broader swath of Californians. I think that's all I wanted to say. So I will turn it back over to Eric. Thanks.
Thank you, Alice. I do want to move now to the next and final round of public comment. And so I'll turn the microphone over to Karen Bloomer.
Thank you, Eric. Wonderful. So until 6 p.m., we will be taking public comment. Again, we will be asking each individual that we call upon to unmute and then provide comment for up to 1 minute. Let's do this. All right. Brian Stomp, we invite you to unmute, please. Please do share any affiliation you have as well. Thank you. Brian, are you able to unmute? There we go. Go ahead, please.
You can hear me now?
Yes.
Oh, thank you so much. I'm not familiar with this stuff. First of all, thanks, Jeanne, the RN, for her courage in speaking for single payer. I belong to single payer now, San Francisco, and Healthcare for All Marin. Insurance companies can't prescribe an aspirin. No one takes a broken arm to an insurance company. They just don't do healthcare. And paying insurance companies for healthcare is just draining money from our healthcare system. We need to uncomplicate physicians' work by getting rid of the insurance companies, get them out of the picture, and realize the $37.5 billion savings for California that was detailed in the Perry report. And all of the commissioners should be sure they must read the Perry report, or they're not doing their homework. It tells how we can finance and get single payer started in California and save $37.5 billion. Thank you.
Thank you so much. Kathleen Healy, we invite you to unmute. Kathleen, go ahead.
Okay. All right, thank you. I'm Kathleen Healy from Physicians for a National Health Program in California. And I take exception to your question, sample question, it's on page 33. Should everyone be required to use this program, or should it be optional? I feel that's a loaded question. People in this country won't even submit to being required to wear a mask during a pandemic. So I think that question is really an unfair question, and I hope that the commission really looks at those questions, and specifically that before they have their public meetings, their community meetings. Thank you.
Thank you very much. Margaret Copey, we invite you to unmute.
Hi.
Margaret, go ahead.
Okay, I'm a physician, I'm a psychiatrist, I'm a member of Physicians for National Health Program, as well as single payer now, and the Healthcare Action Committee and a number of others. And I wanted to particularly comment on the idea that we should consider multiple models that have been tried worldwide. There was a colloquium in January of 2020 called the 7th Annual Global Health Economics Colloquium, and there were a number of researchers who provided excellent data during that colloquium that showed that the European experience of including highly regulated for-profit insurance companies and or nonprofit insurance companies did not benefit from their inclusion. In fact, those programs being included drained their public plans and had a deleterious effect on the populations. Thank you.
Thank you very much. Susan Meyer, we invite you to unmute.
Hello, my name is Susan Meyer. I'm with the California Alliance for Retired Americans. One, I want comprehensive health care, including vision, dental, and hearing for all, including my children and my children's children. Two, some providers won't take new Medicare patients. Three, sometimes Medicare patients are treated differently than someone with a PPO plan. Single payer now. Now is the time. It works well in other countries. I've got to tell you, the cost of supplemental insurance and the cost of medication is killing the seniors. Now is the time for single payer healthcare. Thank you so much.
Thank you, Susan. Deborah Levine, we invite you to unmute. Go ahead. Oh, Deborah, hold on one second. Go ahead. Go ahead, Deborah.
Can you hear me?
Yes, we can.
Okay, I'm Debbie Levine. I work with CAPA, and I'm a retired professor from San Francisco State. I've worked on health policy for about 40 years and advocacy, shifting from being a very strong single payer supporter to wanting to work with the implementation of the Affordable Care Act. I was thrilled to work with CAPA and to see that CAPA was willing to see the life-saving gains that were possible from the ACA and to work to help California develop what I think is the most progressive implementation of the ACA in the country. CAPA has a roadmap designed to do the same thing that this commission is mandated to do, which is to lay out step by step how we can put in place the pieces for a unified system and make gains now, like covering people immediately and so on. I hope that the people who are such strong single payer supporters will be willing to listen to the questions being raised. And I would love to see the chats. The chats have been disrupting my screen. Maybe I don't know how to work it, but the chats are just like this chorus of single payer now, single payer. The question is, what do we do tomorrow to move towards our final goal? Thank you.
Thank you very much. Dr. Bill Honigman, we invite you to unmute. Go ahead.
Yes, thank you. My name is Bill Honigman. I'm a retired emergency room physician from Orange County. I'm very disappointed that the commission is still not addressing actual first steps to be taken for significant reform. And that could be acted upon right now by our legislature. More preventable deaths, especially now during COVID-19, are taking place as we speak, as the commission speaks, as well as opportunities to save substantial amounts of public dollars that can be applied to other public needs. It's frankly shameful that the commission will only commit to monthly meetings in light of all this. We need more meetings and more action now, not 1 or 2 months from now, right now. Thank you.
Thank you very much. Craig Simmons, we invite you to unmute. Please go ahead.
Hi, Craig Simmons, and I'm an advocate for a payroll healthcare tax. I was referred to the commission by Senator Tony Atkins' office, and the Supreme Court approved the Affordable Care Act as a tax, and there are 60% of the population is employed. If a payroll healthcare tax of just 25 cents an hour were implemented and voter approved, that would mean $6 million an hour would go into the state treasury for healthcare, only for healthcare. would enable that amount of money to be lent out to other agencies that needed it or other parts of the state. But the main thing that it would do would give access to single payer health care for everyone.
Thank you very much, Mr. Simmons. Tracy
Thank you.
Rattray, we invite you to unmute.
I'm Tracy Rattray from the California Alliance for Prevention Funding. Thank you for this opportunity to comment. I suggest that the community meetings include a question about what participants think they need to stay healthy. Topics such as access to healthy, affordable food, adequate housing, and jobs that pay a living wage will likely arise and could inform your plans for healthcare reform. Whole person care, which has been well funded by the state, is based on the premise that California residents have a myriad of unmet social needs that impact their health and drive high healthcare costs. Thank you.
Thank you very much. Anthony Sowry, we invite you next to unmute.
Yeah, hi, my name is Tony Sowry. Thank you for the opportunity to comment. I recently retired after a long career that took me overseas very frequently. During these trips, I had the chance to see firsthand how other countries structured and paid for their healthcare, and naturally to compare this to the USA and to California. Alas, the comparison is not a flattering one. The USA is ranked #1 in expenditure per capita on healthcare, and yet only number 46 in terms of measurable outcome. Over 500,000 families turn to bankruptcy every year due to medical bills. Amongst other organizations, I volunteer at HCA in Marin County, and I am lead volunteer in California for the National Patients Advocacy Foundation. The Healthy California for All Commission has a real opportunity to radically reshape and improve the state's healthcare system. The commission is packed with impressive experience, and this is great, but there is almost no representation on the commission or its focus groups for the consumer.
Thank you, Mr.
There are
Sowry.
many organizations that can speak for the patient, and we at NPAF would be delighted to have the chance to do so. Thank you.
Thank you. Nina Eliasov, we invite you to unmute.
Hi, I'm in healthcare for all in Los Angeles, and I'm also a sociology professor. And one of the things I specialize in is research methods. So I have some things to say about the focus groups. If you ask people about their problems with access, you'll get people talking about getting better healthcare in a for-profit system, because people haven't heard of the single payer world, or they won't consider it plausible and realistic. They'll be second guessing what somebody else who would imagine to be realistic, and they also have their own experience, which is that they've never experienced single payer. So they'll just be talking about lowering costs and having cheaper whatever. So this is something that I've written about. A lot of people have written about it. We already know what works, and so I'm not really sure what the purpose of these focus groups is, other than getting people to imagine themselves living in a for-profit healthcare system.
Thank you. Sean Broadbent, we invite you to unmute.
Hi.
Hello.
So why employer-sponsored care must not be included in our future system. Today, the Supreme Court ruled that certain employers don't have to provide essential reproductive care as a part of health plans, exhibiting yet again the indecent limits of the employer-provided insurance model. These types of employers are not small, and in fact, in at least 4 states, they are the largest employer. So under single payer, our employers won't be entitled to make decisions about our care. Under single payer healthcare, our care will be our care and not subject to the prejudice of our employers. So let's end the power inequity of our healthcare system by rooting out the structural reliance on wealth and privilege, and lacking those to have to rely on patronage. So thank you very much, single payer now.
Thank you very much. Looking down to names we haven't heard from yet, and I'm going to call on Jenny Chang to unmute. Go ahead, Jenny.
Can you hear me?
Yes.
Hi, I'm a state and county delegate of the Democratic Party. Please answer the questions that have been posed by commissioners and attendees regarding process. We are demanding transparency, and please post the recordings and public comments as soon as possible following these meetings. It's not hard. I urge this commission to please examine the shutdown of insurance companies in California as an obvious action towards single payer. Removing these middlemen should be a top priority item. Secondly, I'd like to remind this commission that if it doesn't come up with an acceptable plan, the people of the state will find a way to achieve it either way. The call for single payer is that strong in the state. And whatever this commission decides to come up with will reflect on Gavin Newsom. We do see you, Governor. Thank you.
Thank you. Maribel Nunez, we invite you next to unmute.
Hello, can you hear me?
Yes.
Okay. Hello, everyone. My name is Maribel Nunez with Inland Equity Partnership, formerly California Partnership, also part of our HHS network, part of Healthy California Now, and also part of the Immigrant Health Coalition with Health for All. And we appreciate having public comments, and the civic engagement meetings are great. Just making sure that these sessions are after work hours, multiple language, multiple platforms to promote these convenings, and we are glad to help. And yeah, we support a single payer system in San Bernardino County where we do work. There's no county safety net for immigrants, so we need a state strategy that is not employer based. And so please support single payer, and anything that I could do to help, let us know. We didn't get Health for All elders, so it's like, we don't have healthcare for our immigrant communities. They took care of us. We need to take care of them. And yeah, they contribute to the economy. Nobody's asking for papers for sales tax or anything. They contribute within our economy. We need to take care of them. We need a cheap, affordable way for all our communities. Thank you so much.
Thank you. Paula Kat-Bagan, we invite you to contribute next.
Hi, my name is Paula Kat-Bagan. I'm a teacher actually at Ontario Unified School District. And, I'm really glad to hear that so many of us are for single payer healthcare. I guess just to comment on the last discussion about how we get information from the public and, get those people who've never been heard or, don't get heard at all, is that you should be outreaching to organizations. I particularly suggested in the comments that you guys reach out to teachers. We already have this natural connection with our communities. There are a lot of teachers out there that understand the importance of healthcare system, especially a single payer healthcare system, especially in areas where we have high minorities, low SES students, and by connecting with those families, you will get an authentic representation of, who is it that we are serving here in California. Thank you.
Thank you so much. Henry Abrams, we invite you to unmute. Go ahead.
Yes, Henry Abrams, I'm a retired physician, active with Physicians for a National Health Program and the Healthy California Now Coalition. I want to make the point that in the advisory process, I think it's extremely important that all of the participants on the community engagement panels, the key stakeholder panels, and the experts make full disclosure of their financial interests in connection with healthcare and anything related to healthcare, so that we know what potential influences and conflicts of interest might be present. And I think that should be demanded by the commission and published.
Thank you very much. I'm looking for another voice we haven't heard from yet. I'm going to turn to Joel Sarch to unmute. Please go ahead.
Can you hear me?
Yes.
Okay. I'm not going to ask this commission for single payer. I think it's more a case of tergiversation where the commission is not really serious about providing single payer. But I will ask for one thing: make it illegal to make a profit off healthcare. That's all I'm going to ask for. That's it.
Thank you very much, Mr. Sarch. Ellen Schwartz, we invite you to unmute.
unmute. There we go.
There you
If I can
go.
figure out how. Hi, my name is Ellen Schwartz. I think I'm here representing the Northern California region of the Committees of Correspondence for Democracy and Socialism. I'm also active in about half a dozen other organizations that are committed to single payer. I wanted to respond to, I think it was Deborah Levine who admonished us to consider the progressive implementation of the Affordable Care Act in California. And she's right. I think it was probably done better here than anywhere that I know of, but that still left a significant population that remained uninsured, and many people who purchased insurance as they were required to sought the cheapest premiums, which left them with unaffordable co-pays and deductibles. I do know that my granddaughter's boyfriend
5 seconds.
was reluctant to go to the emergency room because he couldn't afford the emergency room copay. We really need single payer.
Thank you very much. Thank you. Beatrice Sosa Prado, we invite you to unmute. Beatrice, we're trying to unmute you. I'm sorry, we'll have to move to Jessica Peregrine next. Please go ahead, Jessica.
Can you hear me?
Yes, we can.
Okay, so I'm a Latina immigrant living in Richmond, California. We, in our family, my husband is a laborer, and we pay $15,000 to $20,000 every year in insurance. And this year we have a bill of $20,000 for a surgery that he's been putting off for 10 years because of the fear of getting a huge bill, and we just got it. So this year we're going to be spending $40,000. Last year it was about $25,000. The previous year it was like $30,000 because we had a baby. We are not able to afford this, but we have to. Like, it's already ripping us. They're already taking our money, but it's not being used effectively, and it's not covering our needs. We don't even go see the doctor because, you know, we always get co-pays, we always get bills. So it's already killing us. It's killing our families and, you know, poor people. So we need to do this as soon as possible. It's about survival for the immigrant community, for people like us.
Thank you very much. Thank you for your comment. I'm going to try to unmute Beatrice one more time. Sorry, I'm just not able to. And I do see that it's 5:57. I wanted to give a couple of moments for Dr. Chen to adjourn. We do have a few more hands up who had spoken previously in the previous agenda. Just want to check in.
Okay, Karen, did you have anybody else you wanted to?
We have 3 more raised hands from individuals that had spoken previously. We'll take those quickly.
Okay.
Okay, thank you. Jeffrey Targadia, would you like to go ahead and unmute?
Yes, this is Jeff
Please go ahead,
Targadia.
very quickly. Thank you.
Very quickly, should we say this is, please find the people, find and come to decisions. Guys, you know, you need to do that. That's my comment.
Thank you very much. Francis Lee, would you like to unmute and speak one more time very briefly? Francis Lee, go ahead.
Yes, hello. Francis Lee, at-large California delegate to the Democratic National Convention. You know, the moral and ethical imperative for single payer is absolutely equity and access to healthcare for underserved Californians. But I would also just like to add, please do not ignore the potential massive economic stimulus and boon for business and industry that it might provide for California. Removing premiums and deductibles would put thousands of dollars of spending power back into the pockets of everyday individuals. And as a tech startup founder, it would help equalize recruiting, whereby I cannot compete with the salaries and the benefits offered by employer-based healthcare. So I think single payer could absolutely unleash a whole new level of entrepreneurship and innovation in the state and further cement California's leading role in that area. Thank you.
Thank you. Caroline Sanders, would you like to unmute? Say something briefly?
Sure. Hopefully you can hear me.
Yes.
Okay, I know it's late, and just wanted to say I appreciate the consumer engagement proposal. CPEN, we just completed 7 focus groups across the state, racially and ethnically diverse groups, where we asked people about their experiences accessing care, which we think could be useful to share with the commission, similar to the CHCF surveys that have also been that someone else mentioned as well. We learned a lot from these focus groups, including that many people still feel very stigmatized and discriminated against when they go to access care, which is still a very real experience, and why these voices must be heard. We have specific thoughts and comments on the questions, which we'll share in writing, but I just wanted to put that out there, and thank you very much.
Great, thank you so much. And we're gonna try one last time with Beatrice Sosa Prado. Beatrice, we invite you to unmute. We're trying to unmute you. I apologize, there must be a technical difficulty. All right, please, Beatrice, do feel free to chat your public comment or to email it to us. And I'm gonna turn it back to Dr. Chen.
Great, thank you so much, Karen. So I just wanted to take the, we're a minute over now. I was gonna take the last minute, but thank the commissioners for your thoughtful engagement and your honest feedback. I am really confident that our consumer engagement will be stronger for the feedback that we got from you. Looking very much forward to digging into the specifics of unified financing and single payer. Wanted to thank the more than 300 members of the public who stuck with us, or at least 200 of them stuck all the way through for 3 hours into the dinner hour. And then just wanted to remind people of 2 things. One is that our consultant team, which also wanted a huge thank you to organizing this. Zoom is never easy. I thought the breakout groups went very well, and hoping that we can refine those as we go forward. They will be sending out a revised version of the report to the commissioners, and we're hoping to get your feedback on that, I think within 7 to 10 days. And there will be ample time for public comment thereafter. And otherwise, I'm looking forward to seeing you all at our next meeting, August 13th. Thank you.
Thank you. Bye-bye.